Should the body's natural pacemaker not perform as it should, it may be indicated that the patient have a pacemaker implanted. A pacemaker is a device that produces the electrical impulses that stimulate the heart muscle to contract. Often, the external variety is used on a temporary basis until the patient's heart resumes its normal rhythm. Think like after open heart surgery. And an internal pacemaker is a permanent method for patients with chronic arrhythmias like bradycardia. Of the types of permanent electrodes used, there are endocardial and epicardial versions. The endocardial electrode is inserted via a vein into the right atrium, while an epicardial electrode is sutured directly to the outside of the heart. The endocardial electrode is far more common. Pacing batteries may be external for temporary use or internal for permanent use. Occasionally, the batteries need to be changed, which will be a scheduled procedure. A defibrillator, on the other hand, is not the same as a pacemaker. Remember, a pacemaker is like a heart's helper, and when it gets out of rhythm or is beating too slowly, the pacemaker helps get it back into rhythm. A defibrillator is used when the heart is fibrillating or quivering and not producing effective contractions, or when there's no rhythm present at all, otherwise known as asystole. Defibrillator paddles can be sterile or non-sterile. If the paddles are deemed internal defibrillator paddles, they must be used sterilely. External paddles do not. Can you think of an instance when a patient may be in need of internal defibrillation? Who do you think initiates the electrical shock? Just like when using an AED, if performing CPR, all personnel must stand clear of the patient during defibrillation to avoid receiving an electric shock themselves. Occasionally, a fibrillator may be used for temporary pacing, or in combination with a defibrillator to create fine fibrillation of the heart. Why on earth would we do that? Well, occasionally an anastomosis may leak, and if the heart is pumping at full capacity, it can be very challenging to effectively repair the leak. Creating a fine fibrillation with the use of a fibrillator causes the heart to slow its beating just long enough to repair a leak, but it doesn't last for a very long period of time, because that would obviously be detrimental to the patient. Using this technique, when appropriate, is a better choice compared to putting the patient on the heart-lung machine. Not that the heart-lung machine is bad. In fact, it's amazing, but it is not used haphazardly. Otherwise known as the cardiopulmonary bypass machine, it takes the place of the heart and lungs by performing the task of diffusion, which supplies the blood with oxygen and removes carbon dioxide from the blood, and then pumps the blood into the body, all by external shunting. In order to use the heart-lung machine, the patient must be cannulated. Specialized cannulas and catheters are used to hook the patient to the bypass machine. Cannulas are placed to continue circulation, but bypass the heart. The surgical technologist must know which cannulas are which, the order in which they are placed, and their intended use. First, the heart needs to no longer receive blood from the body. In order to accomplish this, a venous cannula is inserted into the inferior and superior vena cava. The heart then needs to be perfused with a very specific medication called cardioplegic solution. By definition, this solution paralyzes the heart. It is infused via the coronary arteries through a coronary antegrade perfusion cannula. Once the heart is no longer receiving blood and it's paralyzed, the heart needs to be drained of the blood within it, along with any possible air. Because you can imagine that when you're doing open heart surgery, you might have opened the heart. And when you open the heart, air can get in. When we close the heart back up, we don't want air in it. So these cannulas are going to pump to suck it out. If the heart retains blood while not pumping, it actually has the potential to harm the muscle. So the left ventricular sump cannula and the right superior pulmonary vent cannula are constantly draining the heart while the patient is on bypass. The machine does the work of the lungs and heart, so the blood that is drained from the vena cava shunts blood to the machine, which removes the carbon dioxide and then perfuses the blood with oxygen and returns it to the body via the aortic or femoral arterial cannula. The heart-lung machine has the capability of cooling or warming the blood. And so when the patient is on bypass, the blood is cooled. That cools the patient down, and a cool body demands less oxygen. When the surgeon is nearing the end of the procedure, obviously before they start closing, the patient needs to be decannulated. The cannulas used for the heart-lung machine are slightly larger than the diameter of suction tubing. The heart and lungs need to be weaned off the heart-lung machine in order to resume their physiological duties. The cannulas are removed systematically, and after each cannula is removed, a purse string suture is tied and the hole is closed. By the way, purse string sutures are placed during cannulation so that decannulation is a quick process. It's possible for the patient to experience post-operative bleeding. They could even hemorrhage following decannulation. Can you think of possible complications to this process that might lead to these results? Well, it's possible that the cannulation sites haven't been closed securely. It's possible that heparin has not been adequately reversed. It's even possible that a dissection of the cannulated blood vessel can occur, or if the surrounding tissue has been damaged during the procedure. It's very common for the surgical technologist to remain sterile, and all sterile supplies remain in their place until it is confirmed that the patient is stable in the ICU following cardiac procedures. Waiting for the cue to break, indicating that the patient is stable, can take as long as an hour in some situations.